lecturer of radio diagnosis in Alexander University. The topic is whole body MRI versus PET-CT in the staging of neuroblastoma.
Good evening, my dear professors and colleagues. First of all, I want to thank the organizing committee for the invitation and all the audience who are still there at the end of the conference. I'll talk about whole body MRI compared to PET-CT in the staging of neuroblastoma. Neuroblastoma is an embryonal tumor arising from the primitive ganglion cells forming the sympathetic chain. It is the most common extracranial tumor in children. It arises along the sympathetic chain. The most common location is along the adrenal gland, 20% along the retroperitoneum, and 15% along the posterior mediastinum, and 15% along the cervical and pelvic regions. Unfortunately, 70% of neuroblastoma cases initially present by metastatic disease, with a preferential predilection to metastasize to the bone marrow in 70% of the cases. The bone cortex in 50% of the cases, distant lymph nodes in 30%, and the liver in 30%. In order to treat a neuroblastoma, it has to be categorized into a risk group, utilizing a lot of factors, including the age, the clinical stage, a very important biological biomarkers called the NMIC to categorize the patients. But the most important factor is the clinical stage and the presence of metastasis as the diagnosis results in the child being classified into a high-risk group. The survival rate in the high-risk group does not exceed 40 to 50%. So how to identify the bone marrow infiltration? The gold standard is the bilateral iliac bone marrow biopsy. However, this procedure, the results takes at least 10 to 14 days for the results to show. It's relatively a long time. And the radiological studies, we identify the bone marrow infiltration. The gold standard in the radiological studies is the iodine MIBG scan. If unavailable or MIBG negative neuroblastoma, FDG PET-CT is an alternative. MDP bone scan, however, it is no longer recommended, especially in pediatric patients because of its low sensitivity and specificity. And lastly, whole body MRI. Talk about the FDG PET-CT in neuroblastoma. Most neuroblastomas have elevated FDG uptake. FDG PET-CT is more sensitive than the iodine MIBG scan in neuroblastoma evaluation. However, it is less specific. It can be used for initial evaluation and response assessment. In recent meta-analysis for assessing the diagnostic performance of FDG PET-CT in the evaluation of neuroblastoma, it showed a global sensitivity of 91% and global specificity of 78%. However, there was no significant accuracy of PET-CT in neuroblastoma with bone marrow mets, and challenges regarding the diagnosis of neuroblastoma osteomedullary metastases were observed. Whole body MRI emerged as a versatile diagnostic tool for pediatric oncologic imaging with the potential to spare the children from the harm of ionizing radiation. It allows simultaneous high-resolution local regional staging and wide field of view distant staging with superior evaluation of the brain, spine, and bone marrow. This is the current international neuroblastoma risk group guidelines in the workup for a case of neuroblastoma. What is mandatory is the CT and MRI for local staging. MIBG, as I said, is the gold standard, and only chest radiograph, as neuroblastoma rarely metastasizes to the lung. Alternative and problem-solving modalities is the bone scan, MDP bone scan, radiographs or MRI for equivocal lesions, FDG PET-CT for MIBG negative and, if unavailable, MIBG, and CT chest for suspected pulmonary metastases. What needs further evaluation, as stated by the INRG, is the whole body MRI, so it was the topic of our research. And to compare the whole body MRI to the FDG PET-CT in the assessment of neuroblastoma, this study was performed in Burj Al Arab Pediatric Oncology Center. Pre-treatment FDG PET-CT was performed for all the cases as a part of the standard clinical care for initial staging. 20 patients were enrolled in the study. Whole body MRI was conducted within a period of maximum 10 days before or after the PET-CT. Bone marrow biopsy through bilateral iliac bones was done for all the cases. MRI pulse sequences consists of coronal 3D star, coronal T1 in-phase and opposed phase MRI. 2 or 4 stations were used for whole body coverage according to the patient size. Then the image stations were then fused on the workstation to produce a seamless coronal image. PET-CT was performed starting by the non-enhanced low-dose CT scan, followed by the PET acquisition, and the coverage also extended from the vertex to the ankles. The image interpretation, bone marrow infiltration in the MRI was defined as either focal or diffuse, homogeneous or heterogeneous, hyperintense stir signal. In this case, this is a homogeneous, focal homogeneous stir hyperintense signal. This is a diffuse heterogeneous stir hyperintense signal, showing at the same time T1 hypointense signal compared to the skeletal muscles that showed no signal suppression or less than 20% signal suppression in the opposed phase MRI. Bone marrow infiltration in the PET-CT was defined as abnormal FDG uptake in the bone marrow greater than the activity of the liver. When we compared the whole body MRI and PET-CT in the detection of bone marrow metastases, whole body MRI accurately detected the bone marrow infiltration or lack thereof in all patients with 100% sensitivity and specificity. On the other hand, PET-CT missed 2 true positive cases, resulting in a sensitivity specificity of 86% and 100% respectively. And the overall agreement between the 2 imaging modalities was 90%. I'll present some cases. Starting by this case, this is a 1-year-old girl presented by abdominal distension and vomiting, and further imaging workup revealed a right suprarenal neuroblastoma. Whole body MRI for this case, this is a coronal stir image showing a focal homogeneous stir hyperintense signal involving the left distal femur with a corresponding T1 hypointense signal, with no signal suppression in the opposed phase MRI, with a corresponding high FDG uptake in the fused PET-CT image. And this case was proved by bone marrow biopsy to be a metastatic neuroblastoma. The second case is a 1-year-old child with a left suprarenal neuroblastoma. A PET-CT was initially performed. This is a coronal MIP image for the PET, showing only mild FDG activity, mild symmetrical FDG activity at both femora that was interpreted as hematopoietic red marrow, and there was no suspicion of osteomedullary metastasis. This is the coronal fused PET-CT image showing the left retroperitoneal neuroblastoma, again with no suspicion of METs. Coronal stir image clearly defines the focal homogeneous stir hyperintense signal involving both proximal femora that showed no signal suppression in the opposed phase MRI. This is the axial fused PET-CT image for this case, shows diffuse FDG activity, mild diffuse FDG activity, and there was no suspicion of METs. The coronal stir image clearly defines the focal bone marrow infiltration that was missed in PET-CT and was proven on the bone marrow biopsy. And the final stage was assigned as a metastatic neuroblastoma. The third case is a 1-year-old girl with right suprarenal neuroblastoma. The coronal stir image shows the well-defined right suprarenal neuroblastoma with the normal homogeneous bone marrow of the spine, of the pelvic bones, and of the proximal femora. This is the coronal post-phase MRI, shows the suppression of the bone marrow with no evidence of metastases. This is the coronal MIP PET image, showing again the right suprarenal neuroblastoma with no evidence of osteomedullary metastases. Note this is the normal physiologic brown fat that can be encountered in pediatric patients. And this case was proven to be a localized L1 neuroblastoma. So to conclude, whole body MRI can reliably identify the bone marrow infiltration in cases of neuroblastoma. Hence, it could be used as an initial staging tool, expediting the time needed for bone marrow biopsy and sparing the children the radiation imparted by the PET-CT. Whole body MRI showed better sensitivity than FDG PET-CT and could possibly be used as an alternative to FDG PET-CT as initial staging tool in neuroblastoma. This is our work published in Clinical Radiology for those interested in for further reading. Thank you.
Thank you, Dr. Heba. Any questions?